Gastropharm, even gastroanatomy, even gastro, other than PID, let's go to PID. A 35-year-old female with a history of prior chlamydial infection presents with a low-grade fever and non-specific lower abdominal pain. Examination reveals mild diffuse lower abdominal tenderness and deep palpation. Mild diffuse lower abdominal tenderness and deep palpation. She has cervical motion tenderness and mucopurulent vaginal discharge on pelvic examination. What is your diagnosis? Given the previous history of chlamydia, non-specific lower abdominal pain, and cervical motion tenderness, I am concerned about a pelvic inflammatory disease, with causative agents being commonly Neisseria, gonorrhea, or Mycoplasma chlamydia. I would like to exclude life-threatening causes of lower abdominal pain in a female of reproductive age, and this could include an ectopic pregnancy. I'd like to also exclude ovarian torsion, and other causes of abdominal pain can be broken down into gynecological causes. So this could include adenomyosis, a fibroma, or a polyp that's ruptured. And then gastrointestinal cause of lower abdominal pain could potentially be like to exclude life-threatening causes like a bowel obstruction, and then other causes may include gastroenteritis, appendicitis, cholecystitis, and abdominal aortic aneurysm would also be another cardiac life-threatening cause of abdominal pain. How did I do? What I miss? PID is infection of the upper female genital tract, uterus, fallopian tube, and ovaries. It can involve neighboring pelvic organs. It can cause a tubo-ovarian abscess, and that can increase your risk of the scarring and fibrosis increase your risk of ectopic as well. There's a perihepatitis, pelvic peritonitis. Yep, your differentials can be broken into obstetrics, so ectopic pregnancy, and on that note, placental abruption will cause bleeding, right? What's the difference between previa and obstruction? Versus abruption. Covers us. Attaches. Oh no. Okay, that's not good. Abruption. Gynecological causes. It can be vaginosis. Under gynecological can be for discharge, bleeding, or pain. Discharge, vaginosis, candidiasis, STI. So given that the vaginal discharge, you consider candidiasis, bacterial vaginosis, other causes, STI, and then bleeding, endometriosis, adenomyosis, And malignancy, you'd like to exclude that as well. Didn't mention that. And then GI, well, the kidneys are there, the appendix is there, and clearly you missed UTI. Come on, just look at the abdominal organs. You have your bladder, your renal, collecting system, appendix. Let's restart that question. Okay. My provisional diagnosis, given the presence of prior chlamydial infection, non-specific lower abdominal pain, and cervical motion, tenderness, and discharge, is that... it's too long. My provisional diagnosis is that of pelvic inflammatory disease, given the presence of non-specific abdominal pain, cervical motion, tenderness, and discharge. I would like to exclude other causes of abdominal pain in a female of reproductive age, and this could be broken down to life-threatening causes, which could include an ectopic pregnancy, and then other causes of abdominal pain could be broken down to gynecological etiologies, including ovarian torsion and infectious causes such as bacterial vaginosis, candidiasis, and other causes of abdominal pain including adenomyosis, polyp, potentially it's ruptured, and I'd like to exclude other causes of abdominal pain, which could include pyelonephritis, abdominal aortic aneurysm, urinary tract infection, so like the cystitis, and to rule out pyelonephritis and appendicitis. And I might like to potentially screen for malignancy as well in history and exam. What are some common symptoms and signs? Let's see what the answer is first. Suprapubic pain. It's period-like suprapubic pain. It's abnormal bleeding. So it's suprapubic, it's abnormal bleeding, can be postcoital, menorrhagia, intermenstrual, postcoital, dyspareunia, pain injury, vaginal discharge, fever. So there's pain, relation, abnormal bleeding, intermenstrual, postcoital, menorrhagia. The vaginal discharge is fever. And then that's the symptoms, and the signs include cervical motion tenderness, adnexa, it's the fornices, which is the space between the cervix and the actual vaginal wall, the external os. So adnexa is just surrounding versus fornices. I'm so bad at this. Okay. Yeah, so the fornices is the space between the os and the canal, and adnexa is just this. The adnexa is just the ovaries and stuff, right? Where's the adnexa? Appendages. Adnexa is appendages, fallopian tubes. Yeah, it's ovaries, fallopian tubes, and ligaments that hold it in place. So there's adnexal tenderness, just surrounding organs. Fornices is the space between the external os and the vaginal canal, and adnexa is just surrounding organs and the ligaments. Cervical motion tenderness. Why do they get cervical motion tenderness? What causes chandelier sign? Peritoneal infection. Can add to the differential diagnosis of any process that has peritoneal involvement. Hernia, urinary, gynecological, ectopic, endometriosis, endometritis, PID, tubo-ovarian abscess, torsion, vaginitis, cervicitis. Holy shit. And any peritoneal irritation, and also, okay. Indicate any peritoneal irritation to be seen in appendicitis, diverticulitis. Some conditions are called peritoneal irritation. It can be seen in conditions that cause bowel, gynecologically. Can be present in PID, endometriosis, PID, endometriosis, pelvic inflammatory disease, endometriosis, PID, endometriosis, ectopic pregnancy, yeah, many others. Okay, suprapubic pain, abnormal bleeding. Okay, what are the common signs and symptoms of pelvic inflammatory disease? How do you define pelvic inflammatory disease? Acute ascending polymicrobial infection of the female genital tract associated. Acute ascending polymicrobial infection. What is your diagnosis? Infection. Necral tenderness, vacuum motion, tenderness, fever, discharge. Abundant white cells. CRP. Laparoscopy is a definitive process, but is not recommended for routine diagnosis. Sexually active. Pelvic pain, cervical motion, tenderness, no other cause found. Tuberine access, PID, spectrum inflammatory doors of the upper female genital tract. Endometritis, salpingitis, tubo-ovarian abscess, and pelvic peritonitis. It's beyond cervix. It's endometritis, salpingitis, pelvic peritonitis. Okay. PID is an acute ascending polymicrobial infection of the female genital tract comprised of endometritis, There's a salpingitis. It can be a pelvic peritonitis. Makes sense. It's the endometrium, the uterus. Microorganisms can be Gardnerella vaginalis, Haemophilus, Group B strep. Also can be caused by influenzae, Gardnerella vaginalis, and Group B strep. Gardnerella vaginalis, and the other enzyme, the other bacteria was GBS. Right, so count, and you can do a wet mount of vaginal secretions. We can do a culture, and and NAT for mycoplasma genitalium. Mycoplasma genitalium. Gardnerella vaginalis, GBS. Okay, what's the pathogenesis? The endocervical canal. Must exclude ectopic pregnancy. Oh, he's broken down so well. Oh my god, I should probably just include that directly. Right, and then we'll turn this into a toggle. Okay, so vaginal can be vaginosis, cervicitis, cervical cancer, uterus, endometriosis, endometrial cancer, ovarian torsion, cyst, hemorrhage, polyp, adenomyosis, non-gynecological appendicitis, pyelonephritis. Such a good, clean history. Well, what would we do? Beta HCG, MSU, look for nitrites, leukocytes. MSU analysis looking for nitrites, leukocytes. You can do endocervical swabs. You can do NATs for trachomatis and gonorrhea. You can do gram staining, looking for a gram-negative diplococci. You can culture on a Thea-Martin medium, positive chocolate agar culture, or VCN culture. That's VCN. VCN culture. Thea-Martin agar. Full blood count, CRP, EUCs as well, beta HCG, MSUs, and endocervical swabs. The imaging is not routinely performed. And if I was to do imaging, could do transvaginal ultrasound. With minimal changes but late stage, we may see fluid-filled fallopian tubes, tubal hyperemia, endometrial thickening, tubovarian cysts, free peritoneal fluid, and then invasive. The gold standard is laparoscopy, but it's reserved for complicated or treatment refractory cases. And you could do a pap smear as well. Why not? Because they're looking for viruses. Okay, so what are the risk factors? Sexually active, multiple sexual partners, and then being a partner, and then it can be, you can also get PID non-sexually, and that can be through mechanical disruption of the cervical barrier. That's why it's called an ascending polymicrobial infection of the female genital tract, because the cervix is a barrier. And so any any termination of pregnancy, delivery, surgery, insertion of an intrauterine device. Other causative agents: Neisseria, chlamydia, mycoplasma genitalium. So what investigations would I perform? And then Martin medium. Mycoplasma, E. coli, mycoplasma Neisseria, mycoplasma genitalium. Causative agents: E. coli, group B strep, and origin phase organisms: endocervical swab, microscopy, culture, gram stain, microscopy, gram stain, culture. And we can do a high vaginal swab for a vaginosis, low vaginal swab. And that's to an endocervical swab. You can't use a speculum. You can't do speculum, you do a low vaginal swab. What causes bacterial vaginosis? Gardnerella vaginalis and Prevotella, anaerobic bacteria, Mobiluncus. Oh, don't need to know that. NATs for, both gram staining, chlamydia. You can do NATs, gram staining, and we can do a GM sustain. Do antibodies with fluorescein. Bacterial culture. GM sustain. What organism grows in a GM sustain? Just malaria, treponema. GM sustain. Also talk about how you'd pick up chlamydia. Chlamydia is picked up by a GM sustain. Neisseria, gonorrhea, I can do NATs, isolation of bacterial culture, gonococcal medium, nystatin. Okay. How do you manage PID? What do you see? This is chocolate medium, Martin medium. It's no growth. See inclusion bodies. We can't see any gram staining. Nigeria, gonorrhea. Oh, it's inside the PMMs. So there's chocolate mediums and overgrowth. You wouldn't see chlamydia going on the cultures unless it's a GM. And GM says a stain, it's not a culture. So we wouldn't see anything on culture. The fact that something has grown on chocolate medium tells you it's Neisseria gonorrhea. You can see these gram-positive diplococci, which is also Neisseria gonorrhea. And I'm guessing that shows you something. Vancomycin, colistin, and colistin kills all the gram-negative, and nystatin, VCN. Okay. So the principle here is that vancomycin has gram-positive coverage, and then we have our colistin, which is gram-negative. We have nystatin, which is fungal coverage. That only enables your to grow. Approach to management: we must exclude surgical emergencies. So if you are concerned about ectopic beta-HCG contact positive, then you could do a transvaginal ultrasound to outpatient versus inpatient, supportive versus management, and assess for complications, sexual health education, and assess for the complications. And supportive management is they must avoid intercourse until 7 days after completion of the treatment. If they have an IUD, they might have to remove it if they have PID, and you need to do contact tracing as well. So avoid 7 days after treatment, contact tracing, and educate the patient as well. And if you were to give antibiotics empirically, so if it's mycoplasma, you give your macrolides or tetracyclines, as we've mentioned. Chlamydia, you give your azithromycin, adoxy, ceftriaxone for Neisseria. And if it's anaerobes, normal vaginal flora, such as Mobilicus proteus, you can give metronidazole for anaerobes. For anaerobes, you give metronidazole. Metronidazole is a 5-nitroimidazole that produces reactive metabolites that damage DNA. If it's mild, you just give Kef for Neisseria, metronidazole plus doxy and zithro. Right, and if it's severe, you can give Kef, you can give IV. If it's mild to moderate, you can give AMP and Gent and Metro. If non-STI, you can give AMP for positive, Gent for gram-negative. Ampicillin, amoxicillin. You're not going to remember all of that. Given positive results for gonorrhea, negative results for others, would you still treat empirically? Because negative endocervical screening does not. Well, that, given the positive result of gonorrhea, right, so in PID you treat while the diagnosis, the results are still pending. So you can get adhesions, abscess, Fitzhugh-Curtis. There's liver capsule inflammation leading to adhesions, liver capsule inflammation. You get a perihepatitis as well, Fitzhugh-Curtis syndrome. Following a pelvic inflammatory disease, we may observe. Just cover the whole time. Yeah, Fitzhugh-Curtis syndrome, where you get perihepatitis and that results in adhesions forming violent string adhesions. You can also get an abscess, tubovarian abscesses. You can also get increased risk of ectopic pregnancy, which is very bad. Long-term recurrent infertility, ectopic pregnancy. So the main issues long-term are infertility, ectopic pregnancies. But in the short term, we can develop abscesses. So you can get pyosalpinx, you can get abscess forming. We can have in the ovaries, fallopian tube, can have adhesions. Adhesions can also be present in the liver due to Fitzhugh-Curtis syndrome. This is just additional information. Protective mechanisms, low pH in the vagina, epithelial cells, IgG, common symptoms, subclinical. Let's get this 8-minute timer going, man. Alright, let's see how I go. 8 minutes. Time starts now. Okay, pelvic inflammatory disease. 35-year-old female presents with prior chlamydia infection, low-grade fever. Concerned about STIs, non-specific abdominal pain, PID, ectopic, as bowel, abdominal tenderness, and deep palpation. She has cervical motion tenderness. Given the presence of diffuse lower abdominal pain, prior STI infection, and cervical motion tenderness, I am concerned about pelvic inflammatory disease, which could be either caused by Neisseria, gonorrhea, or chlamydia trachomatis commonly. My other differentials would include infections of the vagina, so potentially bacterial vaginosis. I'd like to exclude pathology of the cervix, including cervical cancer, cervicitis, and moving up, I'm concerned about endometriosis, which can cause lower abdominal pain, in addition to potentially ectopic pregnancy, which is a life threat. It doesn't look good, doesn't work well. Can't take it anatomically. You need to just go off categories. I think that works better. Reset, start again. Okay, my provisional diagnosis, given the presence of non-specific abdominal pain, cervical motion tenderness, and prior STI infection, is that of pelvic inflammatory disease. I'd like to exclude other life-threatening causes of abdominal pain in a female of reproductive age, and this could include an ectopic pregnancy. I would like to also exclude other life threats, including abdominal aortic aneurysm, type B aortic dissections, other pathology of the abdomen, including acute pancreatitis. Other causes of abdominal pain can include gynecological pathology such as endometriosis, adenomyosis, polyps. I'd like to also exclude bacterial vaginosis, cervicitis, and other causes of STIs, and malignancy would also be lower on my list of differentials given the patient's age. And other causes of abdominal pathology could include life threats, including abdominal aortic aneurysm, pancreatitis, appendicitis, pyelonephritis, and cystitis, given the lower abdominal pain. What are the common signs and symptoms of PID? Pelvic inflammatory disease is a polymicrobial infection of the upper genital tract, and it occurs in women often due to sexual intercourse, and can also be due to non-sexual etiologies such as any compromise of the cervical barrier. The common signs can include lower abdominal pain, as seen in this patient, discharge, and often foul-smelling discharge. Regarding the pain can be intermenstrual, it can be post-coital, and there may also be associated bleeding, which is less common. There more commonly tends to be discharge, and this tends to be mucopurulent, and there would be, on examination, findings of cervical motion tenderness, which indicates generalized peritoneal irritation and cervical irritation. What is a pathogenesis and what are the causative organisms? The pathogenesis of pelvic inflammatory disease can be broken down into sexual causes and non-sexual causes. During sexual intercourse, there can be introduction of organisms, most commonly Neisseria gonorrhea and Chlamydia trachomatis, which can ascend up to the female genital tract and cause infection of the endometrium, the fallopian tubes, and the ovaries. And this can give rise to the features of pelvic inflammatory disease. This can also be caused due to compromise of the cervical barrier, and this can occur secondary to pregnancies, intrauterine device implants, terminations of pregnancies, etc. And other organisms that can cause pelvic inflammatory disease can include Mycoplasma genitalium, which is an atypical organism, and less commonly can also be anaerobes in the genital tract, including Proteus. E. coli would also be potentially causative organism, and group B streptococcus. What investigations would I perform? The gold standard investigation is that of a laparoscopy, looking for inflammation of the upper genital organs. However, this is not commonly preferred unless the patient has refractory pelvic inflammatory disease. Initially, we'd like to do bedside investigations. In a female of reproductive age, I'd like to get her beta HCG to exclude pregnancy and ectopic pregnancy. I'd like to do a full blood count looking for evidence of leukocytosis consistent with infection. I may also like to do EUCs, LFTs, rule out any hepatic pathology or renal pathology. Going back to bedside, I might like to also do a urinalysis alongside my beta HCG to look for any renal pathology, looking for leukocytes and nitrites. Going back to my laboratory investigations, I would then narrow down my investigations to identify the causative agent. And this can be done through a endocervical swab alongside a speculum examination, and I could do nucleic acid amplification testing, looking for Neisseria gonorrhea or Chlamydia trachomatis. I'd also consider culturing the endocervical swab secretions, and I could culture it using vancomycin, colistin, and nystatin medium to selectively grow my Neisseria gonorrhea, and I could also consider specific staining for Chlamydia trachomatis, such as the Giemsa stain in microscopy. And on microscopy, I'd also gram stain looking for gram-positive diplococci. I could then proceed to perform an ultrasound to rule out other serious abdominal pathology if required, and I usually would not proceed to any further imaging if my history examination indicates PID and I've identified a causative organism. What do you make of this microscopy? Is gram-negative cocci? If gram-negative cocci were observed, I would be concerned of gram-negative organisms, E. coli, but this is a gram-negative rod, potentially anaerobic organisms, so I might consider adding a metronidazole coverage in the management. If it's gram-positive, I'm concerned about Neisseria gonorrhea, and would still continue with empiric therapy, as other organisms may also be causative. How do you manage PID? Pelvic inflammatory disease is managed both pharmacologically and non-pharmacologically. From a non-pharmacological viewpoint, if the patient is in severe pain, I could consider analgesia. Otherwise, I would focus on counseling the patient for reducing the risk of future pelvic inflammatory disease. I would discuss the severity of pelvic inflammatory disease due to its complications of infertility, abscess formation, and ectopic pregnancy risk. I would encourage the patient not to engage in intercourse until 7 days after finishing their appropriate antibiotic therapy, and I would also engage in contact tracing and also follow up the patient to look for any complications of PID on next presentation. Pharmacologically, I would use empirical antibiotics, and this can be begun aggressively and early given the complications of PID. I could use azithromycin for atypical coverage, and I could use ceftriaxone to coverage Neisseria gonorrhea, and potentially metronidazole for my anaerobic normal vaginal flora, and I would then refer to ETG and titrate my therapy depending on the causative agent identified. What are the complications of PID? PID's complications can be broken down into short-term and long-term. In the short-term phase, pelvic inflammatory disease can cause generalized inflammation, development of abscesses, so it can be an abscess of the fallopian tube or an ovarian abscess, and we may also get the development of adhesions. And we may also get perihepatitis with adhesions forming on the surface of the liver capsule and the anterior abdominal wall, and this is known as Fitzhugh-Curtis syndrome and can cause a right upper quadrant pain following pelvic inflammatory disease. Long-term complications can include increased risk of infertility due to the scarring fibrosis of the salpinx and ovary, and increased risk of an ectopic pregnancy due to the same above reasons. And there'd also be increased risk of further pelvic inflammatory disease. So what's the main swab we're getting? Endocervical, that's what we're getting. And also first catch, looking for STIs, and then midstream for UTIs. So the first catch urine is for STIs, midstream is for UTIs. So now I won't forget when to do first catch urine. First catch urine will flush out all the agents in the actual existing area, which is your STIs. And then your midstream urine would be translocating pathogens from the renal system out, and that would be your UTIs. Didn't mention transvaginal ultrasound, but that's what I would also do. So what's the key points of all of this? Key points are that can clinically diagnosed, gold standard, which is laparoscopy, it's not performed. And full antibody coverage. So I finished anatomy, I finished diagnostics, I finished path. I have, I believe, cholecystitis, IBD. No, I haven't done path. So many damn cases. Got 10 minutes. I can quickly go through acute cholecystitis. So I've gone through that already. We'll do colorectal carcinoma. How about that? And then I'm done. Let's go 10 more minutes. One-year-old male. 78-year-old male presents to the emergency department with fatigue, weight loss, and perirectal bleeding, anemia, thyroid problems, but given the age, malignancy, weight loss, further constitutional symptoms, perectal bleeding, straightaway colorectal cancer. He has a 5-year history of tenesmus, so there is some kind of intraluminal mass that's stretching nerve fibers and causing sensation of requiring evacuation. Hasn't seen his GP for a long time, so probably not screening. On rectal exam, there's a firm non-tender mass in the anterior wall of the rectum, so he's got a colorectal carcinoma. My provisional diagnosis is that of a colorectal carcinoma, specifically a rectal malignancy, and this is given the presence of a rectal mass in the anterior abdominal wall, bleeding, patient's age, and constitutional symptoms. I would like to exclude other differentials for a rectal mass, and this could include hemorrhoids, polyps, enlarged prostate. However, I am highly concerned of malignancy given the constitutional symptoms. Other causes of rectal bleeding could be broken down into upper and lower causes of rectal bleeding. Focusing on lower causes of rectal bleeding, this can be due to vascular malformations such as angiodysplasias, diverticular disease, and as mentioned, colorectal cancer. And upper causes of GI bleeding could include peptic ulcers and esophageal varices, esophagitis, etc. I missed anything? 78, systemic symptoms, got a firm, it's cancer stimulating the rectum. I'll go back to my colorectal cancer diagnostics, go back to pathology. Why didn't I think of adding this? Okay. Hemorrhoids, fistula, abscess. So if it was a painful mass, you're also concerned about an abscess. So neoplastic causes, GI lymphoma. Other causes of malignancy could be a prostate malignancy. Why did I not say prostate cancer? It's a male. He's got a mass. Could be a prostate malignancy too. And carcinoid tumor. But carcinoid tumors are in the lungs. GI lymphoma, anal fissure, anorectal abscess, sigmoid, could be diverticulitis, or PR bleeding. So they've taken it as PR bleeding. Could be IBD as well, angiodysplasia, could be ischemic bowel. The cause of lower GI bleeding could include diverticular disease, angiodysplasia, colorectal cancer. Other causes can include vascular pathology such as ischemia. So mesenteric ischemia can cause GI bleeding, and inflammatory bowel disease, specifically ulcerative colitis, can cause this pattern of disease, neoplastic fissures, abscess. Okay, so we've mentioned all of that. Take it as GI bleeding. What would you like to ask in history and examination? I'd like to characterize whether there's been any other symptoms of GI malignancy. So I'd characterize the fatigue, could be due to a normal chromic anemia of chronic disease. I'd like to also ask about the bowel habits. Has there been any diarrhea, constipation? Altered bowel habits can also indicate malignancy. Any abdominal pain, which hasn't been mentioned in the stem, and any nausea, vomiting, and clarify the amount of weight loss. Past medical history, I'd like to ask whether this has happened before, whether he has any previous medical conditions that can predispose to perectal bleeding, whether it be hemorrhoids, fissures, IBD, bowel habit changes, nausea, vomiting, if there is obstruction, and rule out, look for signs of metastasis. Whenever you have malignancy, also screen for signs of metastases. Right. What investigations would you perform? So I'd be looking for any evidence of organomegaly, masses, and lymphadenopathy. I'd do a PR exam too. Okay, so I'm looking for masses, lymphadenopathy. some main things: pain, masses, lymphadenopathy on exam. What other investigations would I perform? My diagnostic investigation to identify a colorectal cancer would be that of biopsy, and this could be through endoscopy, such as a colonoscopy, followed by histopathological analysis. My investigations may begin bedside. I might like to do a full blood count and follow this with so bedside. I might like to do nothing you do urine. So bedside, I cannot think of any necessary investigations. Bedside, there may not be any necessary investigations. So proceeding to laboratory investigations, I'd like to do a full blood count, EUCs, assessing patients' hydration if they have altered bowel habits and maybe nausea and vomiting. I like to do LFTs, looking for any evidence of liver metastases. And EUCs may also be relevant to rule out any renal pathology. And I could then do look for specific tumor markers associated with colorectal cancer, maybe a CEA, carcinoma embryonic antigen, and I would then proceed to imaging, and this could include staging scans, so CT, chest, abdomen, pelvis, look for any evidence of metastases, and follow this up with gastroenterology consult and consider colonoscopy and biopsy of the lesion. Compare left and right-sided colorectal carcinomas. Left-sided colorectal carcinomas can usually present with overt bleeding, and you might see left-sided colorectal carcinomas typically present with rectal bleeding, whereas right-sided colorectal carcinomas of the ascending colon may typically present with an iron deficiency anemia and possibly even melena if there is oxidation of the blood through its passage to the GI tract. Left-sided malignancies can more commonly present with tenesmus, right-sided typically not, and there may be altered bowel habits. How else would you compare left and right? There's an increased risk of familial adenomatous polyposis, any colonic disease, polyps, FAP, Lynch syndrome, any family history of bowel cancer, any diet, so high fat, low fiber, modifiable, non-modifiable, colonic disease. Oh, I need to finish this up really quickly. So family history of bowel cancer, hereditary, red meat, yep. So ileocecal, right-sided, usually polypoid, exophytic masses. They extend along the wall, whereas they are annular lesions, and they can narrow the lumen and more commonly cause obstruction. So left-sided can cause a luminal narrowing and bowel obstruction. Right-sided can more commonly extend along the wall. They rarely cause obstruction. So more likely to cause obstruction in your right side. No, I'm getting it stuffed. It's your left-sided, yeah. So your left-sided malignancies are more commonly can present with luminal narrowing, constriction, obstruction. Right-sided usually grows along the wall. Microscopically, there'll be dysplastic columnar epithelium. There'll be increased nuclear cytoplasm ratio, mitotic figures, a desmoplastic response where there's collagen deposition, and we may see signet ring cells if it's poorly differentiated. So poorly differentiated malignancies may have signet ring cells. And clinical features, there may be occult bleeding, anemia, be fresh bleeding in left-sided bleeds, change in bowel habits, it can be tenesmus, it can be weight loss, anemia, right iliac fossa mass, left iliac fossa mass, and you may feel a palpable mass in bright red blood. So they're more likely to be gross circumferentially and constrict the womb and cause bowel obstruction. Right-sided will not, and left-sided more likely to cause tenesmus, right-sided more likely to cause iron deficiency anemia. And you typically see columnar epithelium. What epithelium lines the GI tract? Colon. Pseudostratified columnar, simple columnar epithelium with brush border. Whereas the respiratory tract is pseudostratified ciliated columnar epithelium. What are the risk factors? Modifiable, non-modifiable, age, gender, males more likely, previous colorectal cancer, polyps, and then genetic conditions such as FAP and Lynch syndrome. And then non-modifiable risk factors could include a lack of exercise, poor diet, low fiber, poor diet, low fiber. That's it, right? Yep, pathogenesis, it can be due to two pathways. There is the APC or beta-catenin pathway, 80% of colorectal cancers. Okay, we need the APC beta-catenin pathway, in which you get mutations in APC, followed by beta-catenin. Move it to the nucleus, beta-catenin accumulates, and that can cause further mutations. So you can get a mutation in the APC gene, and that may result in the buildup of beta-catenin inside cells, cause further oncogenic mutations in KRAS P53. And there's a microsatellite instability pathway where we get mutations in DNA mismatch repair pathways, and that's what we see in Lynch syndrome. And they accumulate in microsatellite repeats. We can get microsatellite instability. And okay, so normal colon, we get mutation in APC, which can cause, and KRAS, which can present adenomas, and then P53 can progress this into carcinomas. And then there is the microsatellite instability pathway, where it can be germline or inherited mismatch repair mutations, and you get this microsatellite, and that can cause your sessile serrated adenomas. So microsatellite instability causes your sessile serrated adenomas, whereas your normal causes your pedunculated adenomas, sessile serrated. What are the complications of this disease? Well, acutely you can cause bowel obstruction, iron deficiency, anemia, fluid electrolyte balances, cervical surrounding structures, fistulae, Mets, and then it can also cause cachexia, DVT, sepsis. So complications of this disease can be broken down to short-term and long-term. Short-term, the presence of, colorectal cancer is a long-term disease. So break it into paraneoplastic and local. For the malignancy, you can break it into paraneoplastic and local. Locally, there can be local invasion through the bowel wall, formation of fistula. There may be worsening of symptoms causing iron deficiency, anemia, severe pain. There may be fluid electrolyte imbalances, invasion into the bowel wall, Mets, and then paraneoplastic is your DVTP, sepsis, sure. How do you stage it? I thought it was just like everything else, TM staging, right? Stage 1 is T1, T2. I need to know the layers of the bowel wall. There's your mucosa, muscularis mucosa, submucosa, muscularis propria. I swear it was epithelium, epithelium basement membrane, lamina propria, and then your muscularis mucosa, and then your submucosa. So your submucosa is on top now. So submucosa, muscularis mucosa, submucosa, muscularis propria, serosa, and fat. So you have your epithelium, your basement membrane, your lamina propria, your muscularis mucosae, submucosa, your muscularis propria. How am I going to remember this? What's the management of colorectal cancer? What a fat case. Oh my lord. It can be colorectal radiotherapy, chemo, immunoadjuvant, loco-regional. Holy shit. Okay, what are the layers of the luminal wall? There is your... Let me pop up my diagram of biomed. Medicine. Biomedicine notion. So go to rest real quick. See if it makes sense. So I think this path, where I was explaining COPD, and going through so there's an epithelia, lamina propria, your smooth muscle, and then your submucosa. So it's your muscularis, and then your submucosa. So it's the same thing. That's what I was talking about. The epithelium, lamina propria, warm venules, and then you have your smooth muscle, muscularis mucosa. And then you have your submucosa, muscularis mucosa, subendothelial. Sub means under. So you have your mucosa, epithelium, smooth muscle, your submucosa. Thin layer connective tissue, mucosa. Epithelium, basement membrane, lamina propria, then your mucosa, then you have your muscularis mucosa, submucosa, and then you have your muscularis propria, then your serosa. Okay, so T, stage 1, it's invaded all the way to the muscularis. Stage 2, it's invaded beyond the muscularis propria. And then stage 3, it's gone to lymph nodes. And there is N1 and N2. And then stage 4 is met. So stage 1 and 2 is distinguished by invades beyond the muscularis propria and invading to other organs of structure. Weakened by the T&M staging, where the stage 1 is defined as spread up to the muscularis propria. Stage 2 is defined as spread beyond the muscularis propria to adjacent organs or lymph node spread is stage 3, and stage 4 is metastatic disease. So the layers include your epithelium, basement membrane, your lamina propria and your mucosa, your muscularis mucosa, your submucosa, your muscularis propria, which is all the way there. That's your muscularis propria. Epithelium, basement membrane, lamina propria, mucosa, muscularis mucosa, submucosa, muscularis propria, serosa, adventitia. It's like remembering 9 different people's names. Mucosa, submucosa, muscularis, submucosa, and muscularis propria. To accurately manage it, surgical resection of the margins. Stages 1 to 3 is managed curatively, so you can do surgery and adjuvant chemotherapy, the oxyplatin-based chemo. Adjuvant chemo not for radiotherapy as rectal tissue as radiotherapy breaks down the bowel wall. So you don't do radiotherapy because rectal tissue can break it down, so you can do the surgery and neoadjuvant radiotherapy. So you can do surgery and neoadjuvant oxyplatin-based chemo. For radiotherapy is not done. Tumors removed along with adequate resection of the margins. Continuity and anastomosis. Carcinoma within a few centimeters that require abdominal peritoneum. Then we can do radiotherapy, usually for rectal cancers, chemotherapy, and metastatic, and then immunotherapy, and then chemotherapy, and then palliative we just do chemo. So Folfox, 5-fluorouracil, folinic acid, and oxyplatin. We can use Folfox or Folfuri. Management, local excision. So the management of colorectal cancer for stages 1 and 3 can be managed curatively. Stages 4 managed palliatively, and usually with chemotherapy solely. Stage 1, there can be for stage 1 and 2 we may consider bowel resection with adequate margins. This can be the assistance of a pathologist plus minus removal of lymph nodes and regional lymph nodes, and we can then proceed to removal of pericolic nodes, and then adjuvant chemotherapy as radiotherapy can damage the bowel wall, and then for rectal malignancies we can consider radiotherapy. So we can use oxyplatin-based therapies for colorectal malignancies, and for rectal we can use radiotherapy. Stage 4 we can consider using chemotherapy such as Folfox regime or Folfuri, which involves 5-fluorouracil, folinic acid, oxyplatin, and stage 4 is managed symptomatically and using chemotherapy as mentioned. And we can use surgery to relieve bowel obstruction, for example. Alright, that's enough. Microsatellite instability, neoplasia, DNA mismatch repair, sessile serrated, pedunculated. KRAS beta-catenin. What is beta-catenin? It moves to the nucleus and triggers increased transcription. Alright, I'm done. I need to sleep because I have to wake up for trauma very early tomorrow morning. Alright. Thank you for joining, everyone. Hope you guys got some work done.